Pacritinib was recently approved February 2022 for patients with myelofibrosis and platelets less than 50. This is a JAK2 inhibitor. It does not inhibit JAK1, and it also inhibits something called IRAK1, which is in the inflammasome pathway, toll-like receptor, innate immunity pathway. Now, this drug too, like momelotinib, has been available, has been around, I should say, for a while with 3 large trials, PERSIST-1, PERSIST-2, and PAC-203, but it was approved based on the PERSIST-2 trial. And the PERSIST-2 trial was in patients with platelets less than 100, because the unique feature of pacritinib is that it is a relatively non-myelosuppressive drug, and that may or may not be due to its IRAK1 inhibition, but it is unique in that sense. So this trial, PERSIST-2, included patients who may or may not have had prior ruxolitinib, but they all had to have platelets less than 100,000. And ruxolitinib was allowed in the comparator arm. So in the best available therapy arm, they could get ruxolitinib. And just right around 40 to 45% had prior ruxolitinib, and around the same percentage had received ruxolitinib, I should say, in the best available therapy arm. So there's been some recent comparisons, one of which I presented at SOHO this year, of the pacritinib patients from PERSIST-2 compared to ruxolitinib. Like I said, not everyone in the best available therapy got Rux, but a good proportion did. And then a similar proportion had received prior Rux. So this comparison of about 74 patients getting pacritinib 200 twice a day, which is the approved dose, to about 32 patients who got Rux as their best available therapy was presented at EHA and now at SOHO. And pacritinib was superior, significantly so for spleen, as well as for symptoms, but for symptoms, the TSS 50, the p-value was not statistically significant. It trended towards it, but clearly numerically superior for both, and significantly so for spleen. So that's an important piece of data there, because in these cytopenic patients with lower platelets, the question always arises, what should we do? Because we are not able to use an adequate dose of ruxolitinib. We have to use a lower dose because it's myelosuppressive, and you have got to adjust the dose for the platelets. And so now we have an option where we seem to have better preserved efficacy, perhaps because we can deliver a more effective dose.